Morning to all of you. I think we should get started. Good morning to all of you. Let's do it the Brooklyn way. Good morning to everyone. Good morning. Okay, very good, very good. First of all, I would like to welcome all of you to SUNY Downstate Health Sciences University. This is the SUNY Downstate campus. So those of you who don't know the campus, welcome. And also I would like to welcome all of you to the 8th Annual Cancer Health Disparities Symposium. This is the 8th year we're doing this. It started in 2015 from a grant from the NIH, National Institute of Health, to determine the ethnic differences, biologic differences in cancer health disparities. We started with colon and pancreas, and now we are moving into breast and other cancers. The symposium is designed to bring experts together to discuss the differences in cancer biology and also to engage the community in how we can actually come together and solve this issue of health equity in cancer disparities. I would like to thank our partners, Cold Spring Harbor, the foremost. We've been doing this with them for the last 8 years. They've been very strong partners in the program. I also want to thank Northwell Health System. This year we're engaging them in the partnership. Just imagine, we are doing well as a country in terms of cancer. Things are sort of getting better, but if you actually look at the curves, and Dr. Captain will talk about that later, there are still gaps in care, gaps in outcomes. And that is what this conference is all about, to bring all of you together, the scientists and the community advocates and everyone, so that we can all, join forces in trying to figure out what is the cause of the gap and what are the interventions we can put in place to narrow the gap. That is what this conference is all about. And to the best of our knowledge, this is the only symposium focused on cancer health disparities. So it's very, very important. The second goal is to engineer new collaborations. This is, to bring people together as we, the more we come together, the more we're able to, elaborate on issues and then, begin to plan projects that will solve specific problems. As an example, right now we're in the U54 planning phase. A U54 is a huge grant that has science components, training components, and community activities components to it. They are very large applications to the NIH involving multidisciplinary, efforts from different backgrounds. So in order to, make these kinds of efforts, we need a lot of people talking the same language. That is, focusing on the same outcome and then doing the work together. So that's another reason why we're here today, to foster these collaborations so that we can all write and get the money and be able to do the work that is needed to bring the solutions to our people. So to that end, again, thank you to our partners, SUNY Downstate, Cold Spring Harbor, Northwell, and the hospital affiliates, Maimonides Medical Center, Kings County Hospital, and of course, the Brooklyn Health Disparities Center. That is for which I direct at Downstate. Okay, so I would like to invite our Dean of the College of Medicine, Dr. Dean Brunicardi. He's going to give us the formal opening remarks, and then after that, we'll go into the formal program. So thank you.
Good morning, everyone. Thank you, Dr. Salafu, for the honor of giving opening remarks. So good morning and welcome to everyone, those of us who are here in person and those joining us via Zoom. Welcome to the 8th Annual Cancer Health Disparities Symposium. This symposium is the first of its kind in the United States, focusing solely on cancer health disparities. Now in its 8th year, we have invited experts from around the nation to present and discuss ways to bridge racial gaps that we see in cancer rates and outcomes. Here at Downstate, we focus on health equity in our patient care, in our research, and in educating our students. The Centers for Disease Control states that health equity is achieved when every person has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of race, ethnicity, social position, or other socially determined circumstances. Achieving health equity through cancer research and treatment in order to eliminate cancer health disparities is a critically important goal for all in the medical and biomedical professions. Cancer health disparities can present as higher prevalence and with earlier onset of disease, outcomes, patterns of utilizations, or referrals. We see this across minoritized groups, immigrants, members of the LGBTQI community, and people living with disabilities. So today's symposium covers multiple topics in cancer research, screening, and treatment, with a particular focus on serving vulnerable and underinvested, economically disfranchised populations, and most importantly, to reducing cancer health disparities. I look forward to hearing today's presentations and panel discussions from cancer researchers, clinicians, cancer survivors, and patient advocates. Again, welcome to our 8th Annual Cancer Health Disparity Symposium. Thank you.
Thank you very much. All right, a few housekeeping stuff before we start. So we have 3 program directors for this symposium. Myself, I'm the director of the Brooklyn Health Disparities Center. I'm also the chair of medicine at Downstate. I always call myself the medicine guy, the medicine man. But actually, my focus really is in health disparities research. I've been doing this for more than 20 years, very successfully. The other director is not here yet. He's Dr. David Stevenson. He is the Cancer Center Director at Cold Spring Harbor Labs. He's a phenomenal investigator, nationally renowned, cancer genomic scientist. He'll be here, and when he comes, he will give his opening remarks. And then the third person is Dr. Laura Martello-Rooney at the back. She is the engineer for all this stuff, online, and making sure that everybody shows up. Today we have nearly 300 participants for this conference. Some of them are going to be on Zoom and some in person. It's a hybrid. I think the hybrid actually makes it possible for more people to attend conferences, so we are very happy with that. So thank you, Laura, for all the arrangements and the support staff, the CME, for making everything happen, CME office. So today, the symposium is organized into 3 segments. The first segment is focused on colon cancer. The second segment is focused on pancreatic cancer. And the last segment, which starts around 1 o'clock, is focused on breast cancer, right? So that is how it's organized. We will take short breaks in between, 50-minute breaks. At lunch, we will all move to a different building to have lunch, and then we'll come back promptly at 1 o'clock to have the third session. We are very fortunate this year. The keynote speaker is going to blast the room. He's at the back of the room, but we're looking forward to his presentation, Dr. John Captain. He gave a presentation at the U54 planning meeting at Cold Spring Harbor yesterday. It was just, I'm in health disparities research for such a long time, and when I heard what he said, it summarized all my experience into like 45 minutes. It was just amazing what it meant. So we're looking forward to his talk. He's the chair of the Institute for Translational Genomics at University of Southern California. That's just to shorten, but he's an amazing. We will introduce him formally when it's time to speak. So we have incredible speakers as well. I will be introducing the session moderators, and the session moderators will then introduce the speakers. That's how the day is going to go. All right, so in the interest of time, we're going to open the session 1, which is the colorectal cancer session. So that session is now in session. Okay, I would like to introduce who's our session moderator, Dr. Marlene Camacho-Rivera. Could you come up, please, and then moderate the session? I would like to say a few things about Dr. Camacho-Rivera. Just 1 second. Okay. So Dr. Camacho-Rivera is Assistant Dean for Student Affairs and Assistant Professor of Community Health Sciences at Downstate School of Public Health. A social and chronic disease epidemiologist by training, Dr. Camacho-Rivera's research focuses on the role of social, cultural, environmental factors in explaining racial, ethnic, and socioeconomic disparities in chronic disease outcomes and chronic disease self-management in the areas of cancer, asthma, and cardiovascular diseases. Her work explores patterns and explanations for within-group heterogeneity and chronic disease among racial ethnic groups, particularly Latinos, as well as community-based approaches to improving chronic disease disparities. So please welcome Dr. Camacho-Rivera to introduce the session one.
Thank you, Dr. Salafu, for the introduction, and good morning to everyone participating in person and virtually. I have the pleasure of serving as moderator for our first session focused on colorectal cancer disparities. I'd like to start by providing just a brief introduction to our first presenter, Dr. Sophia Stadler. Dr. Stadler received her medical degree from Cornell University and completed her internal medicine residency training at Brigham and Women's Hospital. She subsequently completed her medical oncology fellowship at Beth Israel Deaconess Medical Center in Boston and has appointments as an associate attending physician at Memorial Sloan Kettering Cancer Center and associate professor of medicine at Weill Cornell Medical College. She also serves as the director of the High-Risk Cancer Surveillance and Management Program and associate director of the Precision Interception and Prevention Program at Memorial Sloan Kettering. She also serves as the clinical director of the Genetics Service at MSK. And Dr. Stadler will be presenting insights into early-onset colorectal cancer from the MSK-IMPACT initiative. Welcome, Dr. Stadler.
Thank you so much for the kind introduction, and thank you very much for having me here today. And my disclosure is that I am not a health disparities researcher. I am a medical oncologist and a cancer geneticist, but it has become so obvious in our field that health disparities are such an integral component that has to be taken in whatever field of medicine you're in. And I hope to highlight some of the research that we have done and some of the room for improvement in the research that we have done today. Thanks so much. So what I hope to do today is to give you a broad overview of the MSK-IMPACT program, which is a tumor normal sequencing program that allows us to both understand somatic, so tumor-only mutations, as well as germline mutations that put patients potentially at risk for cancer. I think I'm going to approve this, right? Is that okay? So, and what I'll do is I'll use early onset colon cancer as our example of one of the diseases that we have been able to focus on. And then I'll give you a little bit oversight into some of the recognition of disparities within germline genetic risk assessment that we have faced. So I think it's fair to say in 2023 that genetic cancer risk assessment is an integral component of the oncological care of our patients. It's important in the pre-surgical decision-making arena. For example, for women with BRCA mutations, obviously surgery for breast cancer may include a bilateral mastectomy. In the colon cancer world, more extensive surgical resection of patients with polyposis or at high risk of colon cancer may be undertaken. We have also known for a long time that for our patients with an inherited mutation, ongoing cancer surveillance or even risk-reducing surgeries are an important component for our cancer survivors. And then more recently, I would say in the last 5 or 6 years, it's become apparent that there are a lot of predictive, prognostic, and therapeutic implications for the treatment of inherited cancer susceptibility associated malignancies. A great example of this, obviously, is Lynch syndrome and the utilization of immunotherapy, which has had such tremendous success in MSI-high Lynch-associated tumors. And then last but not least, the reason that really motivates me to be in this field is that we are not only making an impact in cancer patients, we're really making an impact in the family members of cancer patients. So we're really able to redirect families' histories through recognition of cancer syndromes. So all of the recent findings are basically due to the next generation sequencing, which has allowed us to move from sort of phenotype single gene sequencing, which we were doing about 10, 15 years ago, to really multi-gene testing. We have recognized that there are many more genes involved with cancer risk than originally thought. Over 100 have been described. And this recognition has led to not just increased associations, but actually expansion of the guidelines, including NCCN guidelines by ACS and other groups, of who should be tested for genetic syndromes. And this is a continuous cycle that's continuing to expand. So I also want to highlight that traditionally the field of germline cancer genetics and tumor genetics has been sort of different. So germline genetics was really done to assess inherited risk and to counsel families on what surveillance should be undertaken. At the same time, tumor testing was really done to target tumor-acquired mutations for therapy, right? But I think it's fair to say that at this point, these two fields are starting to emerge. We are seeing really the germline becoming an important component of the therapeutic implications in patients with cancer. And I also would say that doing both germline sequencing and tumor sequencing is becoming very, very important. At Memorial, we have chosen to undertake this through parallel sequencing of tumor and normal DNA, but you don't have to do it that way. Certainly you can do tumor-only sequencing supplemented by germline sequencing, but I do think that the two together are very, very important. At Memorial, what we do is we do parallel tumor normal sequencing, and then for the tumor result, we actually pull out, so we subtract out the germline mutations, so only somatic mutations are reported for the tumor. And at the same time, we are also able to assess germline mutations separately using the normal DNA. So this is our current IMPACT panel consisting of 505 genes. And I'll just bring your attention to all of the genes in blue. There are 90 of them, and these are the genes that are associated not just with carcinogenesis in general, but also with cancer susceptibility. So they all have a potential role in inherited cancer risk. The initial paper looking at the first 10,000 cancer patients was published by Ahmed Zahir, Mike Berger, and David Solid and colleagues in Nature Medicine, sort of providing us with an overview of the landscape of somatic mutations in a variety of malignancies. And after this effort, the MSK-IMPACT program was expanded to actually include germline agnostic testing. And the way that we did this is that we offered patients with cancer consent to our somatic mutation profiling protocol, but if they wanted, they could also sign on to a second part, which is really the germline analysis, using traditionally blood, but now we are also using saliva as normal control, and actually in heme malignancies, we have started to use nail as normal control with pretty good results. The patients, we can't do pre-test genetic counseling on all of these patients, there are a lot of them, so they watch a pre-test video educating them about germline risk assessment, risks involved with that, and implications for family members. And then the results are disclosed by the medical or surgical oncologist, and in genetics, we follow them up subsequently. So this is quite an involved process that took a while to put into place. Let me see if I can advance. I think I'm sort of stuck. Thank you. So, all right. So, so this is where we are today. This is pretty fresh as of the last. There we go. As of the last few weeks, we have sequenced over 100,000 tumors, and of those, 32,000 have also had parallel germline sequencing. And what our results have shown is that in general, about 17% of patients with cancer have a germline susceptibility mutation. And of those, the most important ones, which are the high penetrance and moderate penetrance genes, account for about 10% of mutations. So in effect, 10% of cancer patients have some kind of germline susceptibility. What's more important is with parallel tumor sequencing, but what we have also come to realize is that a lot of these patients, probably about half of these patients, don't actually meet clinical guidelines for genetic testing. So this agnostic testing approach allowed us to recognize mutations that wouldn't have been found otherwise. In addition, we have been able to also assess biallelic inactivation in the tumors. So to really figure out whether these germline mutations are driving the tumor, you want to look for somatic events within the tumor. So in a BRCA carrier, you would want to look for example, BRCA mutation in the tumor potentially, or loss of heterozygosity at the region of the BRCA1 gene, potentially implicating that gene as actually driving the tumor. And you can see what we found here, which is that in the patients with high penetrance mutations, there's pretty high amount of biallelic inactivation with either somatic mutation or loss of heterozygosity, suggesting that indeed many of these tumors are truly driven by the germline events. In patients with lower risk mutations, so sort of your carriers or like your recessive conditions, that biallelic inactivation is just not there, suggesting that they're not driving the tumor. This interpretation is really important and helps us to better understand where the cancer is coming from and what is driven by. So, and that gets us to early onset colon cancer. And so early onset colon cancer in the last 10 or 15 years has emerged as a real problem. This is a beautiful review by Dr. Sinekrop in NEJM last year, demonstrating that while the incidence and the mortality associated with colon cancer overall in the United States is decreasing in the 50 to 64 and older population, it's dramatically increasing in the young population and the population under age 50, including increase in mortality. And unfortunately, this phenomenon is not just limited to the United States. What you see here is that there is also an increasing incidence of early onset colon cancer in many other countries in the world. And this is pretty diverse from Australia to India to Thailand to the Netherlands. So it's pretty much all over, with minor exceptions. Moreover, what you also see is that there are racial and ethnic disparities in outcome of early onset colon cancer. We have known for a long time that there are racial and ethnic disparities in all comers with colorectal cancer, knowing that patients who are Black, for example, do worse than patients who are not Black with overall outcome. Unfortunately, the same holds true in patients with early onset colon cancer, as demonstrated by this very nice study by Dr. Stoffel and colleagues published a few years ago in JCO, demonstrating a discrepancy, especially interestingly in stage 2 and stage 3 disease with Black patients having a worse outcome than patients who are not Black. And this is the same for colon and for rectum. And it's interesting that it's not so much in the stage 4 disease, it's stage 2 and 3 disease, which makes you wonder what exactly is driving that. And these calculations were adjusted for county-level poverty, sex surgery, radiation therapy, as well as it was included into brackets of 5-year age intervals. So what are these factors? Well, we don't really know what's driving this increase. Could it be germline genetics? We'll talk about that very shortly. Could it be other things? Could it be exposure to antibiotics? Could it be lifestyle? Could it be metabolic syndrome or obesity that's driving this? Still unclear. And what impact do all of these changes have on our microbiome that could further impact the potential risk of colon cancer? These are all under investigation. So what we decided to do at Sloan Kettering is we have a very large pool of patients with early onset colon cancer, and we compared them genomically and in terms of baseline characteristics to patients with average onset colon cancer. We wanted to assess their baseline characteristics, their somatic genomic alterations, their survivals or their outcomes, as well as their germline alterations. So first, about baseline characteristics, there weren't that many differences. Patients who had average onset colon cancer tended to be a little bit more obese, actually, than our early onset patients. They tended to smoke more just because smoking was more prevalent in older populations. But stage for stage, there weren't that many other differences. You'll see in terms of the, let me approve, Debbie? Okay. You'll see that in terms of race, you'll see the breakdown. At Memorial, roughly about 75% of our patients are non-Hispanic whites, and the rest, about 22% are split between Hispanic, Black, Asian. And you see that distribution here too. And what we noted on clinical characteristics is that these patients with early onset cancer presented in a very different way. Because they weren't undergoing screening colonoscopies, they were much more likely to present with abdominal pain or with blood per rectum at initial diagnosis. We split our cohort into the very early onset, which is age 35 and under, the in-between, which is 36 to 49, and then the over 50 cohort. And what we also saw was that in the older patients who are going to the doctor more and getting screening, they're more often diagnosed on routine colonoscopy or on a blood panel noting anemia, which eventually leads to the workup and to the recognition of colon cancer. More striking was also that the majority of early onset cancers are left-sided, as you can see up here, with really a dramatic shift to the left side of the colon. The reason for this still remains unknown. So we subsequently undertook molecular genomic assessment of the early onset, actually the very early onset, average, and older onset patients, and tried to decipher whether there are any molecular drivers that are driving the early onset cancers. And this is really important because there were some initial studies suggesting that there were molecular differences, but we adjusted this for microsatellite instability status, and importantly, we also adjusted it for tumor-sidedness. We know that left-sided versus right-sided tumors are not the same from a molecular perspective, and they even respond differently to chemotherapy. Once this was adjusted for sidedness, we did not find any differences in genomic signatures in the tumor itself. Furthermore, we did not find a difference in survival of these patients with early onset versus average onset disease. So what about the germline? So does germline susceptibility explain early onset cancers? There are a lot of genes that have now been implicated in colon cancer susceptibility beyond just FAP and Lynch syndrome, which are listed here, and we usually do multigene testing for these patients. The first multi-gene assessment was done by Matt Yergelin at Dana-Farber, where he took 1,000 clinic-based colon cancer patients, irrespective of age, and found that about 10% had a mutation in a germline gene. We also undertook a similar assessment, but we broke down the age categories, and it was sort of enriched for early onset disease, finding that 23% of patients under the age of 35, so that really young onset cohort, had germline alterations. Interestingly, the germline alterations were not specifically enriched in the 36 to 49 age group as compared to the average onset colon cancer patients. Moreover, when you looked, then there was a significant enrichment of colon cancer susceptibility genes, especially in the very early onset cohort, with about 13.8% of these young patients having high or moderate penetrance genes. Lynch syndrome accounted for a large proportion of these very early onset colon cancers. With the somatic germline integration that we were able to do with IMPACT, we were also able to demonstrate that in the very young patients, again, the under 35 cohort, we were able to identify biallelic inactivation in the tumor, suggesting that indeed the germline mutation was in fact driving the tumor. Our data also assess race and ethnicity as a modifier of germline risk. We did not find any, but we were underpowered to really note such a difference. So beyond colon cancer, as was mentioned before, there has been an increase in many other early onset malignancies. So we became interested in sort of assessing this across different malignancies. But the first question that we asked was, well, is age 50 really the right cutoff for what you call early onset disease? And we didn't really know. So we undertook an investigation of the SEER data, and we took the mean age at diagnosis for 32 common cancer types on IMPACT, and we decided to look at early onset, or define early onset, as those patients who had an age of diagnosis 1 standard deviation below the mean for their specific malignancy. So that means if a patient with prostate cancer, where the mean age of diagnosis in the 70s, would be called early onset if he had disease, let's say, under 64. So not all diseases are created equal, and we can't just use an arbitrary cutoff like age 50. Subsequently, we took all of our early onset cases as defined by this method and looked at the prevalence of germline mutations in these cohorts, finding that the very young were enriched in germline mutations pan-cancer, having about 21% mutations under 2 standard deviations below the mean, and 18% with 1 standard deviation below the mean, with much lower rates in patients who were older or who had average onset cancers. So we just submitted this for an ASCO abstract, and so we're hoping to look into this a little bit further. I also wanted to highlight that while MSK-IMPACT germline assessment for the first 15,000 patients was really a research non-billable, so it wasn't billed to the patients, and these patients were already at Memorial and had access to the genetic testing, nonetheless, we still found disparities in how our genetic risk assessment was conducted. There are many studies suggesting that there's lack of access, and insurance are kind of contributors to the disparities in genetic risk assessment for patients with breast and ovarian cancer, for example. But we were a little bit surprised to identify that even in our cohort, again, free genetic testing and same access, the Black patients received counseling and follow-up care for their positive test result less frequently than patients who were not Black. And this has dramatic implications, because if that cancer patient is not receiving the genetic assessment that they need, then remember it has downstream impact on their family members who may also not be getting the appropriate genetic testing. So we are currently have a new process in place where we are very stringent with how we notify patients and how we try to bring them in, tracking all of their results and sending them a tracked letter to increase the uptake of follow-up with our genetic program, which I think is so pivotal to this. And it's really an effort to get at this disparity that we have observed in this population. So in summary, somatic and germline sequencing is really becoming an integral component of cancer care, and early onset colon cancer prevalence is increasing, as is the prevalence of many other early onset cancers. However, it's important to note that there continue to be racial and ethnic disparities in clinical outcome of these patients. They often present with left-sided tumors and more sort of symptoms than average onset patients. However, genomically, they seem to be molecularly not distinct from average onset colon cancer. Germline susceptibility explains a small fraction, about 23% of the really early onset cancers, but there's probably a lot more that's going on. But this does have very important implications for therapy, ongoing surveillance, and again, for the identification of at-risk family members. I do think that the somatic and germline integration can really help to identify the real drivers that could be directed for therapy, and obviously further efforts to overcome some of the disparities in the delivery of genomic care is really needed in diverse populations. And then last but not least, I want to thank our genetics service. We now have 9 MDs on our service and 18 genetic counselors. And I also want to thank all of our collaborators for all of their support. And any questions, please free to reach out by email. Thank you.
Thank you, Dr. Stadler. We'll proceed with our second presenter. We'll take all questions for our presenters at the end of our third presentation. I'd like to now provide a brief introduction for our next presenter, Dr. Daniel Napolitano. Dr. Napolitano received his medical degree from the University of Medicine and Dentistry of New Jersey, completed family medicine residency training at Beth Israel Family Medicine Program, currently serves as the Chief Population Health Officer at the Community Healthcare Network in New York, and as an assistant professor at Mount Sinai in the Department of Family Medicine. Dr. Napolitano will be presenting on colorectal cancer screening in under-resourced communities of New York. Welcome, Dr. Napolitano.
So thanks for having me. I'm a family doctor by training. I'm the Chief Population Health Officer for FQHC here in the city, Community Healthcare Network. And I'm going to talk a little bit about cancer screening, so the beginning part of the journey for our patients, and really more talking about average risk patients. So the goals and objectives for this talk is just to review the national screening rates here and kind of compare them to the Medicaid screening rates, and also to explore some of the healthcare disparities in screening by race and ethnicity. I'm not going to really speak much about the outcomes disparities. I'll leave that to some of the other experts. And then discuss offering choice and that the discussion around that, which we've all been having in the community. And then reviewing some of the evidence-based practices that we might be able to employ to help raise the screening rate for the under-resourced members of our community. So I'll just sort of set the caveat that some of these first slides are looking at the age group of 50 to 75. So that's where a lot of the data still is. And so we'll talk a little bit about that in the future. But here are the national screening rates up till 2018. And really, they have kind of plateaued quite a bit. You can see that the average screening rate hovers in the 60s. People who are older, who access medical care more, have better screening rates. You can see the younger people in these cohorts have the lower screening rates. And just speaking about New York City, we've been living in 69 to 72% screening rates for a number of years now. So we're trying to get to that 80% screening goal that a lot of us are, sort of going for. And it's been hard to move that needle. We've done a lot of progress in the last 20 years. The last couple of years have been kind of flat. And then I'll just show you guys community health center screening rates. And this is national. Again, this is 50 to 75-year-old. This is UDS data. And you can see a dramatic difference in screening rates, right? There was a big dip. You can see that COVID dip that happened. But anyway, right, we're talking about being in the 40s rather than being in the 60s. And that's impactful to our communities. This was published by the Department of Health, and this takes a look at the screening rates up to 2020 in New York State by race and ethnicity. And in general, the screening rates are really equivalent. There has been a dip down in the screening rates for the Asian population in New York State, and so that's the only statistically significant difference in screening. But this disparity really has been, I think, somewhat addressed here in New York State. And then I'll just sort of move over to this recommendation. So, I don't think this is new probably to the people listening to this lecture. It still is a discussion I think that is new for some people, right? In 2021, the United States Preventive Task Force added a new recommendation about screening in people in the ages of 45 to 49 years old. So they brought that to a grade B recommendation. And that sort of speaks to this early onset cancer that we're noticing, this trend in younger people having cancer, that 50 really is not the appropriate starting screening age for average risk patients. And then just to share with people some data, and again, this doesn't have the 45 to 49. I'll talk a little bit about what that screening rate looks like nationally in New York. But you can see there's a progressive sort of increase in screening as you get older, as you access the medical system more. But you can see that younger cohort, the 50 to 54, 50%, 57% screening, as you're getting up into the 70s, we're seeing 84% screening. The age group between 45 and 49 is that much less, right? I think in the prior to that recommendation, the screening rate for the average risk was something in the order of 6%. I don't know how those people got screened, but they did. It's jumped up into the 20s. But we're still, this younger cohorts are areas where we really are finding a lag in screening for our patients. So I want to move over to the discussion about offering choice of screening choice, right? And the United States Preoperative Task Force has a number of sort of validated screening protocols that can be used. And I'm really going to speak about stool-based programs and direct visualization programs. And this is a study I think probably a lot of people are familiar with. This is from 2012. This just kind of started the discussion, I think, more seriously for a lot of us, which was looking at if you offer patients only colonoscopy. The best thing for you is a colonoscopy. You need cancer screening, you got to get a colonoscopy. What this shows is screening rates are quite low. You're living in the 30s and 40s, and this is in a community health center setting, so it's showing that really that didn't really get anywhere close to the amount of screening that we want. When people were offered choice, screening rates went up. So the choice of a FIT test in this case, when this study came out, stool DNA really wasn't being used heavily, but this is a stool-based program versus a colonoscopy, and we see that it really just doesn't work for everybody to just offer colonoscopy, and there's a lot of reasons why. I'll talk a little bit about why that is, but people who don't get screened have no chance of detecting cancer early. They have no chance of that increased mortality benefit, cancer mortality benefit. So this, I think, is a really important, discussion, and I think it still goes on today. This is 10 years later. So just talking about access to colonoscopies and why would it be 30% screening rate if you only offer colonoscopy versus 66% if you offer both choice. And I'm really kind of focusing on our Medicaid populations and our uninsured populations, and it could be applicable to many people, but specifically that in the Medicaid community, I think we're all aware, there was a sort of pent-up demand during COVID where endoscopies really just weren't happening at the rate, and now that still is going on, but this sort of predates the pandemic, that people with Medicaid, people who are uninsured, have much longer wait times to an appointment for a colonoscopy. Despite lots of the great programs that are here in New York City and New York State, there's a wait time, and that's different. And the longer you wait for an appointment, the less likely perhaps that appointment will actually be completed. So that's something just to consider that our patients are facing. Bowel prep, we all know whoever has done a bowel prep or has recommended one is not necessarily the things patients like to do. It can be very inconvenient to people, and it can be particularly inconvenient in some of our under-resourced populations. Our homeless populations, a bowel prep it's really just not feasible for many people. They don't have the access to a bathroom like the way, and you're kind of giving them a choice that they really perhaps can't uptake. Another thing I think we all are familiar with is socially isolated patients who don't have a strong family support. They may not be able to kind of add that extra layer of bringing somebody to the endoscopy suite with them to take them home. And we know, after anesthesia, people need to be brought home. Often endoscopy suites will not, you won't be screened with a colonoscopy unless you can be proved that you can be brought home safely. And that can be a real barrier to some patients. And then lastly, time off from work, a lot of our patients really don't have the ability to get a day off of work for a colonoscopy, right? So these are all pieces that maybe make colonoscopy harder for some of our patients to access. Well, I want to talk a little bit about stool-based programs because there's obviously no silver bullet, there's no easy fix, nothing is perfect. Some of the challenges I think that have come up in the last couple of years around stool-based programs, and I think a lot of FQHCs have taken up stool-based programs, and they really say, like, our patients are accepting this more commonly. This is a good tool, and it is. This has similar mortality benefit. There really is a need to sort of implement in a systemic way screening for risk. The recommendations for stool-based testing in colon cancer are really for average risk patients, and there's still it's a growing area of sort of implementation for FQHCs and other community health centers to really sort of methodically weed out the people who are high risk, who really should be offered colonoscopy first, as far as we know, and really stick to the average risk patients. So that is something that still, I think, is evolving for a lot of us. And then serial screening. The mortality benefit, although if you have a positive stool-based test and you get a colonoscopy, there is sort of lasting mortality benefit. If you have a negative, right, the FIT tests are meant to be done every year. FIT DNA, so-called Cologuard, every 3 years. They only really get that mortality, but the studies show that you get that mortality benefit from serial screening. And there's a lot of evidence that serial screening doesn't happen the way we would like them to in the FQHCs. So sort of tracking serial screening, making sure that our patients who the year before got a FIT test and it was negative are coming back again for their next FIT test is really an important aspect of stool-based programs that I think we have to really focus on. And then the next piece, which is, what about our patients who have a stool-based, they've average risk, they've chosen the stool-based program, and they're FIT positive? How fast do they get a colonoscopy? Do they ever get a colonoscopy? It's certainly part of the recommendation in the conversation when you're having with patients, say, if this is positive, I'm going to refer you for a colonoscopy, but how many patients really get there? We're finding that a lot of patients are not getting there to that, and the rates that are sort of quoted from the mortality benefit where uptake of the diagnostic colonoscopy was in the high 80s, we're not seeing the same thing in a lot of FQHCs across the city, and that's an area of focus for, I think, a lot of community health centers. So I'm just going to talk a little bit about some interventions, some of the evidence for them, and what we can do to sort of get to that 80% screening in every community approach. So, proactive outreach there are many studies about proactive outreach, different types of outreach. And, in the community health centers, I think the question is, how much bandwidth do you have to do that proactive outreach? So the classic phone call is a very labor-intensive outreach program that has a very low yield. It's important, it can make a difference, but people don't necessarily have the staffing to sort of invest in that kind of outreach. There has been a lot of research going around in community health centers recently that's showing that text campaigns can be very effective. They can be effective across racial and ethnicity, different backgrounds, and serial texting, if you have that capability, is a very sort of cost-effective way to sort of raise your screening rate. And those can just be, happy birthday, you turned 45, time for your screening. It can be, we gave you a FIT test last week and we don't have it back yet. Please call us if there's a problem with completing it, or we're going to remind you again next week. And so those type of campaigns really have been proven to move the needle. Bulk mailing can work too, and there's evidence to suggest that that's sort of cost-effective and maybe easy way to send mailings. I think when you're talking about proactive outreach, I know a lot of MCOs have taken this approach, and that's because it is proven to bring back a return on investment. About 20-30% of people will complete a FIT if you just bulk mail to everybody. The problem, I think, in those programs may be the opportunity to screen for average risk sort of gets taken out of the picture, I think, a lot of times. So I think we have to think about when we're doing bulk mailing is, are we bulk mailing our average risk patients, or are we just bulk mailing every single patient? And that may not be appropriate, right? Phone calls, I sort of talked about that. There is some evidence to show that automated phone calls can work just as well as live, and that people find those acceptable. And so that could be a lot more sort of doable in a low resource settings to use. And then patient portal and email, probably there is evidence that patient portals have made a difference in a lot of outcomes. There also is evidence that perhaps our patients in the community health centers are not accessing patient portals in the same way, and that we may be generating healthcare disparities, or we may not be sort of fixing healthcare disparities if we only focus on the patient portal. Pre-visit planning, there's a number of different EHRs sort of being utilized in New York City. I'm just sort of focusing on New York City. Some of them do have pre-visit planning already sort of built in, some do not. Actually, in a lot of FQHCs, that is just not a standard that happens. It's not sort of what many of us might be used to in some of the other EHRs. But building those in does raise screening rates. I think there's probably how you implement it that matters more about how much you change behavior of your providers. And the more pre-visit planning you do, the more it does become background noise. So you have to kind of really be targeted, I think, in what you're asking, reminding your staff that needs to be done. And I think, really you have to take that team-based approach. So all staff have to know what to do with that pre-visit planning, and it really starts when the patient checks in. It doesn't start when the patient gets in front of the doctor or the nurse practitioner. So, just talk a little bit about other outreach that has evidence behind it that has been effective. That follow-up sort of FIT testing, there has been evidence that serial follow-up for people who do not return their FIT tests can really significantly improve return rates and completion rates of FIT tests. So whether they be live or automated, whether they're serial text reminders or patient portal reminders, there is evidence that that can improve the return rate. The average return rate for FIT tests is something between 30 and high 40%, maybe 50%. So if we can increase the return rate, if we can increase the completion rate of our FIT tests, we can get more people screened. And then, reaching out to patients who have done the test the year before proactively, not waiting for them to come to the office, not waiting for them to have their annual, but to actually say, hey, 1 year ago today, you completed your FIT test, it was negative, time to do it again. Those type of programs can make a difference in screening rates. I'll just sort of talk a little bit about this. This is not as much, we know there's a lot of evidence for cancer navigation and how that can improve screening rates. But I think just in the FQHC setting, which is very rich in support services, using the entire team to sort of target subpopulations within your groups can really be effective. So many of our patients have health homes, and sort of engaging our health homes to be engaged in cancer screening as well as chronic disease management is an effective protocol. But many of our patients may not have health homes, but they may be exposed to other patient navigators. People living with HIV often have patient navigators involved in their care. So I think bringing in all the other team members and the resources that are available to you in an FQHC so that everyone can sort of focus on the population that they have relationships with really can bring up the screening rates for your population as a whole. Financial incentives. Sort of a mixed bag in evidence, and what do I mean by financial incentives? There are studies that show that offering patients some sort of financial reward for completing a screening test has some impact. Some studies say yes, some say no. I think the same is true about offering providers or teams sort of financial incentives. There is proof that that can make a difference, but it's sort of mixed. So I will say it's out there. Is it the best driver? Not sure. And then I just wanted to briefly touch on data reconciliation. New York City is just a particularly wonderful place with a very diverse, sort of perhaps fractured healthcare system where we have multiple hospitals, multiple systems, multiple community health centers. We don't all have the CMHR. We don't all see the same data. But really trying to find a way that we can all work together to share data with each other, and then that we're getting closer and closer to that, to sort of share with each other that this person has been screened, this person has not been screened, and really we can sort of create an efficiency, I think, that is missing here in the city, and we can sort of focus on the people who truly haven't been screened a lot more effectively. I think a lot of us have the experience of, have you ever had a colonoscopy? Yes, I had it. Where did I have it? I don't really remember. When did you have it? I'm not really sure when. And then what do you do with that, right? You just have to either hunt it down, which is a very labor-intensive process, or you have to rescreen those patients. And either way, perhaps a waste of resources if we can all kind of share our data a little bit more effectively together. So a lot of the population health platforms out there are trying to do this, trying to bring in information from the MCOs, bringing in information from other sources, and sort of really put it all in one space for population health teams to sort of look at and manage and try to pursue the right populations who haven't yet been screened. And I know there's a lot of work going on in the RIOs trying to bring in that information to us all so that we can sort of take a look and know our screening rates in a more easy way, regardless of the EHR that patients are using. Just lastly, community outreach, I think, is a big, important part of population health and colon cancer screening. And I think special events that have worked in the past, like a flu fit program. People are coming in for their flu shot. This is a chance to also get you screened for colon cancer. That has worked very well in the past. Sort of reaching out to your community-based organizations and having staff events and sort of bringing forward that idea of this 80% screening in every community, and that we can break our communities up into small communities, small populations that we really have access to as different members of the healthcare team, and try to go for that 80%. Cumulatively, we'll get there together as a group. So just some takeaways. Screening rates are improving nationally, but there still remains a large gap in our under-resourced communities. Multiple evidence-based interventions have been described but to achieve, I think, the 80% screening rate, community health centers really need to take a multi-layered approach. There's not one thing fix for this. And then efforts to utilize automated reminders and outreach, I think, is a really important resource that we have to be focusing on as community health centers to really sort of get to our patients, help them complete the screening, help uncover some of the barriers that they might be experiencing to complete the screening. And improved data sharing may improve efficiency and reduce duplication of efforts. So thank you very much.
I'd like to introduce our last presenter in this panel, Dr. Rebecca Rhee. Dr. Rhee obtained her medical degree from Tufts University and completed her residency training at Bay State Medical Center and fellowship at St. Luke's Roosevelt Hospital. She currently serves as the chief of the Division of Colon and Rectal Surgery and director of the General Surgery Residency Program at Maimonides Medical Center. And Dr. Rhee will be presenting on emerging treatment strategies for rectal cancer. Welcome, Dr. Rhee.
Good morning, everybody. I just want to thank the organizers for allowing me to very humbly talk to you today about rectal cancer. I have no disclosures. So the objectives on my talk are very simple. The first is to really give you an overview of our traditional treatment paradigm for rectal cancer. And then I'll discuss two newer strategies, total neoadjuvant therapy and watch and wait. So, as you all know, colorectal cancer is one of the most common cancers diagnosed. Worldwide, it's the second leading cause of cancer death for men and women combined. And approximately 1/3 of rectal cancer, of colorectal cancer, are in the rectum. And so it's very common. What is the ultimate goal for treatment? Of course, we focus on the best oncologic outcomes, which include obtaining a negative resection margin. As a surgeon, the circumferential margin is very important. Local recurrence rate, this is very specific for rectal cancer, and of course, overall survival. But it's not just about the best oncologic outcomes, it's also about quality of life, and that includes recovery time from surgery, from chemotherapy and radiation as well, postoperative pain, morbidity, and mortality, and sphincter preservation. So we've made large strides in terms of avoiding permanent ostomies for patients, and also overall function. Even though you can reconnect somebody, it's important to make sure that they have function afterwards. So why is rectal cancer unique? Well, the anatomy, it all comes down to the anatomy of the rectum. So the rectum is in a very fixed, tight space in the pelvis. It's the last 6 inches of the large intestine, and of course it plays a critical role in defecation and in your maintaining your continence. So traditionally, cancers in the other parts of the colon are treated with surgery, but because the rectum is in a fixed space, it becomes very difficult to access with surgery alone, and that's why we have evolved to give these adjunctive treatments. So what is the current treatment standard? So if you have locally invasive rectal cancer, that's stage 2 and 3, those patients will receive, in addition to surgery, they will receive neoadjuvant chemoradiation therapy, and that's typically followed by adjuvant chemotherapy. So I'm going to just talk about a little bit about the data in terms of why we do it this way. There was a landmark study published in the New England Journal of Medicine in 2001 by the Dutch Colorectal Cancer Group. And what they showed was that preoperative radiotherapy with surgery compared to surgery alone showed an improved local recurrence rate. The overall survival was similar, but the recurrence rate improved from approximately 8% to 2.4%. And so that's why we give radiation therapy in addition to surgery. Now, is it better to give the radiation therapy before or after? So this study in 2004, again published in the New England Journal of Medicine by the German Rectal Cancer Study Group, demonstrated that it is better to give the radiation preoperatively. So if you think about it intuitively, if you give it pre-op, you will be resecting the organ that has been exposed to all of that radiation, which is toxic. And so what they were able to show was that, again, there is the benefit of improved local recurrence rate, but the morbidity due to the radiation was significantly reduced. And you can see here, overall survival was the same. And so that's why we give the radiation preoperatively rather than postoperatively. Of course, as a surgeon, I need to talk about the standards that we hold ourselves in terms of surgical technique. So the surgical resection still remains the cornerstone of definitive colorectal cancer treatment. 1982, Bill Heald, he's a pathologist from the UK, he actually described the holy plane of the rectum. And he published this in the British Journal of Surgery. You can see here in the lower picture, the rectum is in a fascial envelope. So in the old days, we used to dissect bluntly, a lot of surgery was done openly, but now with our minimally invasive techniques, we strive to really keep this plane intact. And what they were able to show is that if you use this technique, you have, again, improved local recurrence rates. So all the way back in 1996, this kind of affirmed Dr. Heald's findings. There were two groups of patients studied. Over 200 patients were in each group, and what they were able to demonstrate was, again, a very significantly improved local recurrence rate, down to 6% compared to almost 20% in patients who had total mesorectal excision technique, maintaining that fascial plane. So again, just bringing you back to this overall balance as a clinician, this is always my ultimate goal. The question that we have to pose is, can we do better? As much as I love doing surgery, can we do better? And so this is Dr. Angelita Habergama from Brazil. She's the one who really posed this question: is surgery really needed? A preposterous idea. She actually brought this up at the American Society of Colorectal Surgery meeting in 1998, and legend has it that she was booed off the stage, kicked off, because it was so preposterous what she was suggesting. So what she suggested was organ preservation. Can we preserve the rectum? Do we even need to do surgery? And she suggested that her patients would get neoadjuvant chemoradiation therapy, and she would just follow them every 1 to 2 months. And if the patient recurred, then they would move on to surgery. So how did she come up with this? Well, we know that about 20% of patients that have the neoadjuvant chemoradiation and then get radical surgery, 20% of them have a complete pathologic response, meaning once they look at the specimen under the microscope, they can't see any cancer cells, so no more cancer. And in addition to this, a similar cancer in that area, anal cancer, has undergone kind of a similar type of evolution. So in the beginning, with anal cancer, patients would get chemoradiation therapy with radical surgery, obligating them to a permanent ostomy. But with the advances, we now treat the patients primarily with chemoradiation and avoid surgery altogether. That's for anal cancer. So from those two pieces of information, that's how Dr. Habergama came up with her treatment strategy. And so what we're looking for is a complete clinical response. These are the patients that are candidates for watch and wait. So number one, in their history, patients will often have very significant symptoms, including rectal pain characterized by extreme pressure, bleeding, and changes in their bowel habits. That will all kind of disappear. On physical exam, of course, you're looking for no irregularities, ulceration, or stenosis. You'll often feel a thickening or a firmness, a rubbery firmness as expected. On endoscopy, as you can see in this picture, and on imaging, instead of this horrible ulcerated lesion, you're going to see a flat white scar with telangiectasias. That's evidence of a complete response. And on MRI, you'll see low signal intensity, no detectable abnormalities, and absence of increased signal without any significant lymph nodes. So you can see here significant thickening, and now it's gone to completely smooth. So it's pretty amazing. So what she was able to show initially, this is all the way in 2013, just to give you some perspective on how long she's been pushing for this. She did a prospective study on 70 patients, and these patients received chemoradiation therapy. And what she found was that 10 weeks, 68% of them had a complete clinical response, and at 12-month and 56-month follow-up, there were very low rates of regrowth. So at about 50% of those patients at 56 months did not show any regrowth, and therefore these patients were able to avoid surgery and potentially a permanent colostomy. So you have to ask the question, well, what's the rate of local recurrence? And if you do recur, does that affect your overall survival? And so this is another study by Haber-Gama. She discovered that really your overall survival does not change. So she found in this study 49% of these patients had a complete clinical response. But there was a significant local recurrence rate. It was up to 31%. But what she did find was that overall survival was not significantly affected, and those patients were able to undergo surgical intervention without any adverse effects on their survival. And in her study, 78% of those patients were able to undergo organ preservation. So this is pretty amazing. So in order to improve the complete response rate, we've kind of evolved towards total neoadjuvant therapy. So what does that mean? That means that patients are given all chemotherapy and chemoradiation prior to any definitive surgical treatments. Well, what's the benefit of that? The benefits include an increased rate of treatment completion. So it's very difficult to undergo full chemotherapy after you've had this very radical surgery, most often with a temporary ostomy. So they found that even up to 30% of those patients don't even finish the chemotherapy regimen, which is 6 months long. So the benefit that they found for TNT is that patients will be able to complete their therapy. In addition, there is definitely an increased rate of complete clinical and pathologic response. So this is a study published in 2019. It was a systematic review and meta-analysis looking at 28 studies, and what they were able to find that total neoadjuvant therapy increased the odds of complete response up to 39%. There have been several other studies that have been published showing even higher rates of complete clinical response. This is a retrospective analysis published in 2021 by Sloan, looking at stage 2 or 3 rectal cancer patients from 2012 to 2019. Again, the intervention was total neoadjuvant therapy. They found a complete response rate of almost 40%. Only 6% developed tumor regrowth, and the recurrence-free survival was higher in the watch and wait group compared to people who underwent the traditional treatment. So what is really the correct recipe? Is watch and wait the future? Well, things need to be figured out. One is that we need a standardized protocol as to who will undergo watch and wait. And the key is really patient selection. So what the data has found is that patients who have undergone watch and wait are those who would require a permanent colostomy, as opposed to tumors that are higher up. So again, patient selection is key. You really have to accurately identify also patients with complete clinical response. So it can be difficult to identify those patients with complete clinical response. The techniques are still not perfect. I've had patients that have had abnormal imaging that have undergone surgery and the pathology shows complete response. And I've had patients that have had totally normal imaging, but we move forward with surgery and they end up having residual cancer. So still needs to be figured out. And the consistent follow-up. We don't know exactly how to follow these patients. We just know that the recurrence rate is much higher within the first 2 years. And so at those points in time, you have to watch the patients very closely. And is TNT the new treatment paradigm? I would like to suggest yes, because it increases the rate of organ preservation. It's a much better tolerated treatment. But you have to ask, or are we giving patients unnecessary chemotherapy? Chemotherapy, of course, has negative side effects. Most significant is a neuropathy, which can be very debilitating for patients. And the other question is, are we delaying definitive treatment for patients? This all still needs to be determined. So in summary, multidisciplinary approach around patient-centered care is really it's all about finding the balance between patient quality of life and survival. The development of advanced minimally invasive techniques is inevitable, and further investigation is needed to determine their overall safety and efficacy. And the new focus of interest will be, of course, on survivorship. It's not all about, of course, you want the patient to survive, but you want them to survive with good quality of life. And ultimately, it's important to acknowledge that in the end, it's the patient who takes all the risk. And as clinicians, it's our mission to make sure that these new evolving treatment strategies are available to all patient populations. So that's it. Thank you very much.
Thank you. Now I'd like to invite all of our presenters to the stage for us to open up to a question and answer portion. And I'd like to start, if that's all right, by taking some questions from individuals who are in person in the audience with us today.
I have a question, if I may. So the early onset colon cancer problem that we now have, is it clear that younger adults are having polyps? Is there something different about the biology here? Even, let's say we screen everyone when they're 30. Are we actually finding polyps in young people? Or is this a different biology that we're seeing in the young with colon cancer? I guess it's a kind of a question for all three of you, but Sophia is the one who concentrated on the topic.
So outside of the patients with germline susceptibility, where there are often increased polyps, I don't think that's really well known yet because we haven't had large surveillance studies in young patients. And actually, it's sort of a conundrum because when we have patients undergo a colonoscopy at a very early age, for some reason, they have blood per rectum and they get a scope and they have a larger adenoma. What does that actually mean for them? I have to tell you, genetically, most of those with just one polyp, they test negative, So we're not sure what the prevalence is yet. I think the 45 to 50 age group, we're going to learn a lot, right, as we expand colon cancer surveillance or screening to that population. But I think in the earlier cohorts, I don't think those studies really exist yet. But I'd love to hear your comments.
Yeah, I don't know. I think that seems appropriate. As we increase the screening rate of that cohort between 49 and 50, perhaps we learn more about why this is happening. It seems, you listed some reasons of what the theories are for why there is this increase in younger age, and I think it seems to be unknown. So.
Yeah, great. And I guess just to follow up on that, I think one of the other things that we're observing with early onset colorectal cancer is, this really high rate increase in Hispanic Latinos specifically. And so it begs the question, right? What's the sort of proportion of that's related to genetics versus diet and environment, lifestyle, right? Underlying genetic ancestry. And so, I was looking at sort of the racial, ethnic makeup of the impact. Do you think you have enough, or are you exploring and stratifying by race and ethnicity any?
It's a great question. We did try to stratify it, but we are underpowered to really detect if there is a difference. Yeah, it's a really good point. And I think Dr. Rooney is doing some research here. I'm trying to ascertain more of the patients who are outside of the non-Hispanic white, right, community. And I think that's really, really important. Again, a lot of potential for collaboration, actually.
I have a question. Enjoyed the presentations. I noticed on one of the slides you showed how with African Americans that were counseled in terms of their genetic mutation, that was still a huge health disparity with that. So I was just curious, how diverse are your physicians and the genetic counselors? And the reason why I ask that is because, I think one aspect of this is if the genetic counselor or physician looks like the patient, that can help cut down on some of the maybe health disparities. So I'm just curious, how diverse are your physicians that are seeing the patients and the genetic counselors?
That's a really great question. Unfortunately, the fallout is upstream of the genetic counselor. They don't even make it to the genetic counselor. But your question applies to how diverse is the physician, nurse, APP population, right? How can we reach these patients? And I think Dr. Yinglu, who I mentioned, that study is sort of following up with additional cohorts focusing actually on endometrial cancer for obvious reasons. It often occurs in non-whites, especially in higher prevalence in blacks, but also it's associated with Lynch syndrome, so it kind of brings those two things together. So it's a really interesting study, or a really interesting population to study and try to address this. Yeah, it's a good question.
Dr. Salafou?
This question is for Dr. Napolitano. The question has to do with the goal of 80% screening. That goal was up for 2018, right? We are now 2023, and you said we are stuck. So can you explain why we are stuck and what can we do to unstuck ourselves?
Yeah. So that's a great question, and I was sort of part of that. I think a lot of us were of that 80% in the 2018 goal, and we, I think, made a lot of strides as a nation, but we did not get to 80%. We still, nationally, certainly haven't gotten to 80%. In New York City, we really haven't gotten to 80%. And now the sort of messaging has changed to an 80% in every community. Mm-hmm. And I think this sort of change of looking at sub-communities and trying to achieve those 80% is really an important way, because what does your community mean? It means a lot of different things to a lot of us. What can we do to get unstuck? We really need to do a little bit of everything, is my opinion. And I tried to present some of those interventions, but I think we really need to engage right from the beginning. Our providers and our healthcare system needs to be very keyed into the importance of colon cancer screening and make sure that we're not missing opportunities. We need to have diverse healthcare providers so that our patients and our healthcare system, are linked with each other, and that the recommendations are being taken up. And also we need to reach out to our communities in lots of different ways. Small media, big media, I think community-based organizations. We really need to show everybody the importance of this. There's been a lot more publicity lately around colon cancer, but I think still not enough. And I think the awareness needs to be raised as well. So.
For Dr. Rhee, thank you so much for expanding on the rectal part of the conversation, because most of the conference are on colon, but I see that you are doing the colorectal part of it. So thank you for doing that. My question to you has to do with any disparities. Do you see surgically, is there any difference in outcomes between the various racial groups or ethnic groups, or surgical outcomes are the same? I don't know.
That's a good question. I would say I feel like culture definitely plays a very large role in terms of if patients can make it all the way through the treatment regimens. I tell my patients when they come in that it's really a journey, specifically for rectal cancer. Everybody comes in, they want a quick fix, just surgery and be done with it. And it's really difficult for them to understand that it is a journey. It takes about a year from beginning to end to undergo all of that treatment. And in terms of cultural impact, a lot of patients don't make it all the way through. So I think there is definitely a difference.
One question from Dr. Martello-Rooney.
This is for Dr. Rhee. So we have a translational study focused on colon cancer. The reason why we focus only on colon and not rectal cancer is because we need fresh tissues for developing our organoid research models, as well as for the sequencing that these tumors undergo. So we've been excluding rectal cancer patients because they undergo the neoadjuvant chemoradiation, and that essentially, obviates our ability to then get fresh tissue. So my question to you, just because I don't know, is, are these tumors biopsied? And if so, if we're able to potentially get fresh material that way before the patient starts their treatment course, then we could, possibly begin to look at rectal cancers, because I think you can agree that it's a different disease entity compared to colon.
Yes, absolutely. They're definitely biopsied before. I guess it would depend on how much tissue you would need to do your testing. But it's interesting because rectal cancer is so complex, it's gone in so many different directions. I know I spoke about TNT and watch and wait. There have even been questions about whether we can avoid the morbidity of radiation or chemotherapy. So that's why it's really a multidisciplinary approach. Each patient gets their own unique plan. And in terms of the rate of complete response, I'm sure it would make things complicated for you in terms of receiving adequate tissue for testing. So it's definitely a much more complex beast to study.
Thank you. We have one question from the chat. The person wrote, "My question is about less invasive methods of screening. The speaker did not mention CT colonoscopy as an option. What is the utilization of this tool in New York City, and can this not help improve access to screening?"
That's a great question, and it is one of the accepted screening methodologies of a non-invasive CT colonography. I think very underused, and I can't really quote a rate. If somebody else has one, I don't have it, but I know it's a very low rate compared to stool-based programs and direct visualization, but it's an effective tool for some people. It can be maybe more palatable. I don't have any sort of data to quote about how much more palatable it is across race and ethnicity or across economic status, but it is a viable screening method, and I think maybe underutilized, I'm not sure.
I think there is a bit of a misconception as to CT colonography. It's still pretty invasive. The patient still has to do a full bowel prep. At the time of imaging, you have to drink a whole bunch of contrast, and then you get air pumped up the rectum. So it's still a little uncomfortable. I think from an anesthesia standpoint, because you don't need to be asleep for that study, that's what makes it less invasive. So I think that's probably part of the reason why it's underutilized.
And also one follow-up. So if you identify polyps, then the patient still has to undergo a normal colonoscopy.
Yeah.
Correct?
Yep, absolutely.
Yes, I guess I would just add that non-invasive, a FIT test or a FIT DNA test is probably the most convenient way of testing.
There's another question in the audience.
Yes, good morning, everyone. In our communities, we have, I think, one of the presenters spoke about persons with, it showed on the slide, persons with Medicaid, persons who are uninsured. And a lot of those persons, when they do go out to the facilities and they may have some sort of a cough or whatever it is, but they are not receiving the proper treatment, the proper testing to see exactly what is happening with them. And some of them, they are afraid to go out there because they are uninsured. Then you have persons in our communities also who have, I would say, the immigrant status is not in good shape, so they are afraid to go out there because they said, hey, I don't want to go out there, and then I get sent back home or whatever the case may be. And at the end of the day, when it's too late, then it's too late. And then my other question is also, there are those persons who've went out there, they had the testing and everything done, and when it comes to the chemotherapy, they refuse it because of the adverse effect that it has on them. So what other alternative treatment do you have for them when it comes to chemotherapy, or patients who don't want to go through chemotherapy? And even for the community healthcare we have here, what type of information would you have for them that they could pass on to those patients who are not insured and they don't have the coverage to go out there to get the proper treatment that is needed?
Those are great questions. I'll take the screening, or start with the screening piece of that. I can address some of that. You're right. There are a lot of barriers to getting screened if you are uninsured, underinsured, and I think you hit on some of the big parts. There's a lot of fear about being screened. There's a lot of fear about the implications of maybe cost. Maybe you may think, oh, this is free, and then maybe it's not really free, and you find out later that you have a bill you can't possibly afford. Even, I sort of mentioned a little bit, people don't all have the same access to taking off from work, and that can be or taking away from watching their family or their children, and so those are other barriers. And to your point, it really does need to get in front of people all different ways. The communities have to be, people have to feel reassured that, first of all, that testing is available, that testing is important, and also that it can be done. There are programs in the city, thankfully, Community Cares, I think a lot of us are familiar with, sort of helps the people who are uninsured find colonoscopies for free. The health and hospital system and a lot of other endoscopy suites have participated in that. There's not enough. I would say there's not enough access to really accommodate people quickly, and I think you have commercial insurance. You're getting if you come to the space where you need a colonoscopy, you can do that quite quickly here, and it's not the same for uninsured, and there's sort of somewhere in the middle for the Medicaid community. And so I do think we need to be talking about it in all sorts of ways. This is just sort of one-off, some programs that are not necessarily focused on cancer screening, but that engage patients who are uninsured, undocumented in the healthcare system in other ways. We have a strong PrEP program, for example, in our community health center. There are a lot of young men and women who are eligible for colon cancer screening. They didn't come for that, but they need to be offered that on top of the thing that they came for, which might be PrEP. And so I think these days of waiting for annuals, waiting for people to come for their screening appointment, we have to walk away from that and get people wherever we can.
Yeah, just to touch on your last question, I agree with you. It's definitely a challenge because some patients do refuse chemotherapy, but it's really about tailoring the treatment for them. So I've had patients that have refused chemotherapy and we move forward with surgery. I think it's really about patient education and kind of walking them through all the risks and benefits of those treatment options. And I will just say as a little caveat, I think immunologics and immunotherapy, which depend largely on the biology of the tumors, are an alternative to chemotherapy in some cases, but again, I think it all needs to be further studied.
Well, this concludes, I think, our first session. So thank you again to all of our presenters, and we'll have if there are any additional.
We do have another question.
Oh, okay, this will be the final question. Was getting the wrap up earlier.
Sure. Excellent presentations, honestly. We recently at Downstate had a conversation on artificial intelligence, especially GI Genius, playing a role in early detection of adenomas. I just wanted MSK's perspective in early detection of early onset colon cancer, if there is any role of GI Genius being there. And since it has very high sensitivity of detection of adenomas, I was just curious, will it be like an overkill if we identify that in a very younger population?
So I'm not sure. I don't know what do you mean by GI genes? Is that what you said? I'm sorry.
So it's something like GI Genius. I was just curious about it. We had a talk on artificial intelligence recently.
Artificial intelligence.
Yeah,
okay.
And the role of it in early detection of colon cancer, especially in younger populations. It has very high sensitivity of detection. I was just curious if it will be like an overkill or not in younger population if we end up finding more adenomas, which do not particularly signify colon cancer but are pretty benign.
So I know our gastroenterologists have some research studies underway using AI in the high-risk populations, but I don't know of anything like that in for the general population. I mean, you would imagine that eventually it may move to that arena if it's successful, but
I don't know if that, yeah, but it's a good thought, yeah.
I might just add, there are some, I'm not aware of them in the colon cancer screening space, but they're happening. AI is being used in outreach and in follow-up successfully in other disease states, and I think there perhaps is a role there of screening and detection and sort of having those chatbots have conversations in a way that we just don't have the human power to pull off.
Yeah, actually, Kings County has GI Genius now, and they're just starting to utilize it as of December. And I have a GI fellow that's working with me in the lab that is going to retrospectively review 2019 ADR rates and then compare it to 2023 to see if it's actually going to essentially decrease miss rate.
Well, that officially concludes our first session, so thank you to all of our presenters again.
All right, I really want to thank the speakers and the moderator for keeping the time. In every symposium, time is of essence, and everyone kept their time. That is why we had enough time to have the discussions. So I'm hoping that the next sessions, please keep your time so that we can have enough time for questions and answers. Okay, so this next introduction is very interesting because the solution to health disparities includes academic and community partnerships. Right, so the academic stuff has to happen, the community stuff has to happen, the two have to come together for a solution. So I'm going to introduce Arkell Cox. She is a community activist, businesswoman. She's the CEO of Diamond Girl Productions, honorary doctor of business administration at St. Francis College. She's actually a member of the board of trustees and governing executive board at St. Francis College as well. She does a lot of stuff in the community. Most importantly, she has a very, very powerful family story. That is very impressive whenever she talks about it. And that is why we invited her. So she's leading a huge colon cancer program in Brooklyn, in the community. And we are so blessed to have her come to have a few words with us. In addition to her talk, we have a former U.S. Congressman, Mr. Ron Klink. He's also here. He's also going to make a few statements. He's also, investing his life after U.S. Congress duties to the work of colon cancer in the United States. He's also here. He's also going to make some statements. So, Arkell, please come to the podium.
Good morning. Okay, I know it's early and everybody's like on a lull, but we're gonna get some energy now. So I wanna say thank you, Dr. Salafu, because this is extremely important to me. Everyone is talking about March is National Women's Month, so kudos to all the women in the room, yes. But more importantly for me, as a woman, that means a lot. But more importantly, I'm here today because I want to talk to everyone in the room, the doctors, the faculty, the community activists, other people just like myself who have a reason to be standing here today. So as Dr. Salafu said to you earlier, I'm a community activist for colorectal cancer. Why? Because I like to wear the color blue and represent it this month? Absolutely not. My husband passed away 10 years ago. He was 40 years old. We were very active in the borough of Brooklyn. We own pretty much a majority of the IHOPs in Brooklyn. 10 years ago, we were just starting out. We were just building our families. We had 2 children when my husband passed away 10 years ago. 7 and 14. I see a lot of you shaking your head. At 40 years old, how does this man, 6'4", 240 pounds, pass away of colorectal cancer? His mother and father, thankfully, thank you God, are still here today. There's no family history. So what was the miscommunication? What did we miss? And for me, I feel like we missed the natural conversations. We miss not knowing what are the signs, because in our communities, we don't really talk about colon cancer. There's a lot of stigmas with colon cancer. So for us, for instance, if I was a young girl at home watching TV, and I'm scowling at the TV, and then I go to my mother later on and I say, Mom, I got a headache. She'll say, because you were squinting. You got to go to the ophthalmologist, right? And so you got a toothache. We go to the dentist. That's a natural conversation that we will have around the dinner table. But the conversations that we do not have in our community is, why is there blood in my stool? Why am I constipated? I've changed my diet. Why am I losing weight? All of these things need to be customary. These are the things that we need to talk about. We need to find out our family history. We need to find out, what did our ancestors, what did our great-grandfathers die from? A lot of us in this community are from the Caribbean. We have that Caribbean heritage, and we don't ask questions. It's taboo. And then the younger generations, the other taboo is that a colonoscopy, because of the negative connotation, the doctor spoke about it earlier. She said, you know, the prep alone is mind-blowing, right? How do we change that? Do we know that there's other forms of prep that you can take if your insurance pays for it? But it's a conversation. But if we're not opening the door for these conversations, we're going to continue to lose people in our community. I have called, for the past 10 years, my children and I, we call colon cancer the cowardly cancer. And so I'm not a medical doctor, I'm honorary doctor, right? But so the medical doctors in the room, I'm sure you'll agree with me when I say that nobody has to die from colon cancer. If we are talking about it, if we are letting our communities know that if you can walk into a hospital and you can say these things, there's blood in my stool, I'm constipated, I'm feeling that there's some type of, gas, some type of air in my colon, my stomach area. And you get that recognition to know that, you know what, this is warranted. Maybe we should see, do they need a colonoscopy? But because they don't have insurance, or because it's not a conversation, or we're not educating ourselves in our community, that goes unheard. If there's polyps and you get the colonoscopy, you can go home that day. It's the best 7 minutes or 10 minutes of sleep that you're under. You go home, you resume your life. But if you continue on with those polyps living and growing in your body, that cowardly cancer becomes aggressive. It takes over your body, it takes over your life, and by the time you are seeing signs, by the time you are feeling sick, you've already gotten this thing in your body, and it's a little too late at this point. So I'm here today to tell you, we need to stop thinking that we can't have these conversations. I want everyone in this room to go home today and to have this conversation. So I met a really nice lady, but she's hurt, she's broken. Her 2 children who are doing amazing. My daughter is one of the #1 leading runners on her track team in the state of New Jersey. She's the fastest runner in the state in her high school. My other daughter signed to SUNY, but I stand here today to tell my story so that nobody in this room has to deal with standing as one parent when you're supposed to have another. When my husband died 10 years ago, we were building our lives. We were 40 years old. We were ready to take on the world. Now I have to stand here and tell his story. But I'll do that to save somebody else's life. I'll do that to implore you to have a conversation at the dinner table. It is imperative. So when I connected with my sister Alicia here, who's been a friend of mine for over 20 years, who's actually my husband's friend before I even met her, I said, I got to get to these doctors in the hospital. I don't care what I got to do. If I got to come, I got to stalk them. But we need to figure it out. My husband grew up around the corner on Linden Boulevard. This is his community. We have to start within our communities. But I just don't stop here. The congressman is here today because I dragged him out here, because he's gotten me into the rooms in Congress. We've gotten before the Congressional Black Caucus. We've spoken to so many people to change the laws, to get recognitions in our community, but we can't do it alone. I can come up here and I can tell you my story and you can feel my pain, but if we're not talking to those in our communities, if our doctors are not telling their staff and their faculty to be more mindful when a young man, a man comes in that looks healthy, he looks healthy. So in our minds, because he looks healthy, my husband is 6'4", and he's athletic, and he doesn't drink, and he doesn't smoke, and it must be an autoimmune disease. No, he has blood in his stool. He's constipated. He's losing weight at a rapid rate. So obviously, that's a sign for you to tell your staff, maybe we need to get this guy a colonoscopy. And if that conversation had been had, I wouldn't be standing here today. But I don't question God. Everything is for a reason, right? So I know that my husband's death is not in vain. I stand before you here today, and I thank Dr. Salafu and his staff. And, oh God, it's just so many doctors that I've been on the phone with in the last couple of months to say thank you, because you heard my voice and you made today possible. I'm sitting here next to Dr. Salafu this morning, and I'm getting texts. I got a text from my attorney, and he said to me, please get me the information. How can we get the men of our community in to get a colonoscopy? How can we get them screening? Access is key. We want to save their lives. Another gentleman is here. He's a creative director, Felton. Where are you? Are you in the room? Hi, Felton. So Felton is a very ambitious, young, creative director. He works with the biggest names in the music industry. You name them, Felton has worked with them. He has curated their albums and their videos and their graphics, and that's how I know Felton, is through one of my attorneys, but as well as I hired him to work with my daughter who signed to SUNY. And in a conversation maybe 2 weeks ago, I don't know what happened, but he said something to me about colon cancer, and he says, I need to get a colonoscopy, but I don't know how. Felton is intelligent, he's smart, he has his hand in everything, but just a simple conversation is, he don't know how. So yesterday, he hit me and he says, hey, can I still come in? I need to get the information how to get a colonoscopy. This is one of 6 calls since I've had him in this building, because everybody knows that this is colorectal month. I brought Congressman Glink here with me today, as well as my partners. And so when I say to you that our best fight to eradicate this disease, for us to get ahead of it, is just communications, is talking, having that conversation with our friends and family around the dinner table, and also reaching out to other people. As I said, I didn't know Congressman. I met him through one of my partners at Behavioral Health, which is, I'm going to let you talk about what we do with that. But I say all this to say, come on up here, Congressman. I say all that to say is that we can't keep this cowardly cancer in a box. We have to talk about it. Just the way we talk about what did you have for breakfast, what did you do yesterday, and social media. I want to talk to the doctors in the room, right? And so our staff, it seems like there's a disconnect when the doctors were talking here. Dr. Daniel, where are you, Dr. Daniel? You are a great asset for people like me in the community, because we can link with you. We can get the information out there. We can use social media. We can have the conversations. It is key. Nobody has to die from colon cancer if we can get them their colonoscopies in time. So I'm here today to say to you, please help me. I've been doing this for 10 years. I will continue to talk about colorectal cancer, getting screening, getting the information, and making sure that nobody has to stand in my shoes. I thank you, and I'm going to introduce my dear friend, former Congressman.
Thank you very much. I will take just a few moments of your time because I'm not a doctor. I don't even play one on TV. But Dr. Salafu, thank you. We've spoken before, and Dr. Salafu understands what we're about, and it touches me every time I hear Arkell tell her story. So to Dr. Salafu and Dr. Napolitano, what do you do to get beyond where you are if you're stuck? It's a great question. And I think we have the answer. I'm working with a group called Rehavior. It's a behavioral health group that I found. And we're working on a lot of chronic conditions to get people to do the things that they should be doing to get a better health outcome. But you can't do that until you find out what are the conscious and subconscious thoughts that are getting in the way of them doing that. For example, we did a study with the University of Pennsylvania on colorectal cancer. And the University of Pennsylvania said to us, look, 68% of the people in our group, the general population, get colorectal examinations. They don't get them as early as they should. They don't get them as often as they should, but they get them. Now, when we talk about African American men over the age of 50, it's a different story. It's 18%. And it's like Dr. Napolitano and Dr. Salafu said, it's stuck. What do we do? And so, working with very smart behavioral scientists out of MIT, we went to work on this. And we were able, if you can get a 5% or 10% change, that's pretty good, right? We were able, by establishing a baseline of 4 questions to ask them on intake, 4 questions, takes 3 minutes. We doubled the number of men who were getting colorectal exams, from 18% to 36%. Still not as high as it should be, but 100% increase. It's very, very dramatic. Now, here's the best news about that. There are CPT codes. CMS realizes this behavioral science works, and they have CPT codes, so this is all billable to Medicaid and Medicare, and reimbursable $75 to $100. So how can you afford not to? Number one, you're getting money back in, you're getting more people to participate, and you're getting a better health outcome in your community. I will be fortunate to Dr. Salafu to let you know that I'll be at the Cancer Moonshot meeting next Friday at the White House. I've been asked to be there, as well working with a group called StopColorectal.com, who my dear friend Arkell is working with as well. So I don't want to take a lot of time. We will be here. With me also is Ken Rotondo, the founder of Rehavior, and Tarini Gupta, who is a behavioral scientist and one of the smartest young people that I've ever met in my entire life. We will be here if you want to know more about this. We'll answer any questions, but we think we can help you. We've just recently also completed, we've done diabetes, we've done other chronic conditions, but we just recently completed a study on substance use disorder, which we're going to be rolling out very soon as well. But right now, it's colorectal cancer, and we know we can make a difference. Thank you for giving me your time.
We are really, really on time. It's just amazing. So thank you again. But I have to recognize my partner at Cold Spring Harbor, Dr. David Stevenson. I did introduce you, but I want you to stand up and be recognized. And if you want to say something, I heard your voice. Oh, he stepped out again. Okay. All right. In the next session, he would probably give some few opening remarks before we continue. But we have time. We'll take 10 minutes break. So thank you.